Next up is Professor Jones. I don't think he needs any introduction. He's written an 18,000 downloaded textbook on rapid response systems, which I know is his most proud professional achievement. I'll leave Darryl to explain. He's going to talk about ANZ code study. Thanks, Darryl.
Thank you. Thanks very much, Alex. And Alex did the beautiful post-production in that ebook. So Julie's just alluded to a little bit about the background to the study, so I'm going to skip through that. I'm going to talk about what is known about in-hospital cardiac arrest, the study aims for our prospective study, and inclusion-exclusion criteria, and then the results and the implications of those. So as Julie's alluded to, the quality of data about what happens during in-hospital cardiac arrests in Australia and New Zealand, in fact, is not particularly very good. There's huge variation in the reported frequency, and in Gerard's systematic review, there was very little data on the initial rhythm, and the details, particularly of the epidemiology of the demographics of the patients. There was very little, if any, on the details of life support, and I'm not aware of any publications at all that looked at the duration and the nature of intensive care supports of patients, which is extraordinary when you think about it, including very little from overseas. So the aim of this study was to evaluate the epidemiology of ward-based cardiac arrests in the context of mature rapid response systems, and we looked at the frequency, patient demographics, details of the arrest, details of the ICU management, and hospital status discharge. And Gemma's going to talk about the functional status, both at hospital discharge, but also at 6 and 12 months, because there's almost nothing on that for in-hospital arrest, particularly in Australia. This is a multi-centre prospective study, and like many clinical trials groups, we had a management and writing committee with site investigators, standardised case report forms, encrypted transfer, and a prospectively developed statistical analysis plan, and that's the organising committee there. We had adults, so greater than 18 years, and our definition of a cardiac arrest was someone who was unresponsive, had no respiratory effort, and received external cardiac compressions. Importantly, we did not use pulse check, and I'll talk about that in a minute, because that's the modern definition of what constitutes a cardiac arrest in Australia, and I think that's a very important caveat in this study, but also in our future management of cardiac arrests. Alison, we don't do pulse checks anymore. And we excluded patients. They had to have a documented not for resuscitation order, so if the team turned up and they decided, we probably shouldn't, sorry Julie, they're included. So you had to have a documented not for CPR order. If you got an isolated cardioversion, for example, a shockable rhythm, we didn't include that. And in non-ward areas, we didn't include those as well, because the main reason for this study was to look at patients who might have benefited from rapid response teams, and that will be the subsequent studies. We're going to look at the potential preventability, but also the potential patients that should have been for ECMO. They'll be the subsequent studies we're going to look at. So this is a busy slide. I'm just going to concentrate on the guts of it. The study was done roughly over a year. It's relatively contemporaneous. The data is now about a year old. The thing was that these events are quite infrequent. We had nearly 16,000 rapid response team calls, almost 500,000 hospital admissions, almost 200,000 multi-day admissions, so that's after excluding dialysis and same-day surgery, etc. And there were only 159 ward-based cardiac arrests. So when you work it out, it's roughly one a fortnight per hospital. So the median was 2.2 per month. And when you look at the rates, if you do multi-stay admissions, it was 0.3 per 1,000, and multi-day admissions, it was 0.6 per 1,000. In America, they're talking about less than, this is United States of America, less than 2 per 1,000 as a desirable target, and we're at 0.6 multi-stay admissions. So what I'm going to do now is take you through the results. They're quite detailed, and what I'm going to do is talk about a lot of fractions, and these are very rough, but I think it's a useful journey to go on. This is just published in the September issue of Critical Care Resuscitation, so you don't need to jot lots of notes. As Julie alluded to, roughly 2/3 of our patients got return of spontaneous circulation, and a half of all of the patients went to intensive care. So that's a big deal. We're roughly getting one admission per fortnight to intensive care following a cardiac arrest, and we'll talk about that in a discussion. Roughly half of the cardiac arrests occurred in the first 4 days. That's perhaps not surprising. It's when the patients are most sick, haven't had a chance to respond to treatment, and if you look at the median length of stay of most hospital admissions, it's roughly in the order of 3 or 4 days. So that's not surprising. But I guess if you want to invest bang for buck, you would do lots of intensive monitoring in the initial phases of a hospital admission in patients that are at risk. And about half occurred in daylight hours, which I think has important implications for the deployment of ECMO CPR. And Aidan's going to talk about that in a bit. Roughly 2/3 were male. Roughly 2/3 were admitted under a medical admission as opposed to a surgical type admission. And although cardiovascular risk factors and chronic disease was common, this is a very important point. Only 40% of the patients actually were admitted with a cardiovascular related diagnosis, if that makes sense. They came with respiratory, orthopedic, musculoskeletal type conditions. That's on that slide there. Very few patients had a documented limitation of medical treatment. Now that doesn't mean that some of them shouldn't be, because I didn't mention the median age was 71, but a quarter of them, so that upper quartile range is 81, a quarter of them were older than 81 years old. And as we'll see, Jim will talk about maybe age isn't the be-all and end-all, but that's a pretty old age demographic to be performing CPR in my opinion. And most of them were home, the vast majority. So this is the features of the cardiac arrest. 2/3 of them were not shockable rhythms. Although 3/4 were witnessed, and I think that's a representation of staff being around, taking vital signs, lots of these hospitals had nurse rounding, only 40% of them were on monitors, actually telemetry or coronary care. And we didn't distinguish between coronary care and telemetry because sometimes it's not obvious in individual hospitals what that is, but we're talking about continuous electronic monitoring. Roughly 2/3 of them got adrenaline. Now, I'm not aware of any other studies that have looked at in-hospital cardiac arrest to look at this type of data, and consistent with ALS guidelines, roughly 1/3 got defibrillation, roughly 1/3 were shockable, and relatively few patients got amiodarone and atropine, consistent with our guidelines. It's basically quality CPR, adrenaline, and early defibrillation for shockable rhythms. It's pretty easy to teach this approach to treatment these days. The median duration of CPR, I thought this was quite short, but we actually, Ronaldo and I sat for 6.5 minutes. It's actually a relatively long time to sit for doing it, and a quarter had CPR for more than 18 minutes. Interestingly, 1/5 of the patients had CPR for less than 2 minutes, okay? And I suspect, as we'll get to in the discussion, that some of these patients may not have been truly arrested, but they may have had profound hypotension and unresponsiveness. And I think this is a really positive thing to come out of modern CPR management, is that we don't mess around doing pulse checks. I suspect that some of these patients would have been pulseless to feel. Results continuing. So this is the ICU management, and as I said in the introduction, I'm not aware of any other study reporting this level of data. The intensity of treatment was high, and the duration of treatment was often prolonged. So you can see the duration is often the order of 40 hours. So a couple of days, with a quarter of patients getting treatment for more than 90 hours. So 4/5 got adrenaline, 1/3 got noradrenaline rather, 1/3 got adrenaline infusions, 1 in 10 patients got ECMO. They were at 2 centres only. 4/5 got invasive ventilation or non-invasive ventilation, and 1/3 received renal replacement therapy. So this is a big deal, and I'm sure you've all seen this. And so, as Julie alluded to, prevention is surely better than cure. And these are the in-hospital outcomes, and Gemma's going to talk a lot more about this. Approximately 40% survived a hospital discharge, and approximately a quarter went home, which I find extraordinary, given the history of outcomes of in-hospital cardiac arrests. So the discussion, I think, is that these events are relatively infrequent, and most events were non-shockable. And I think this, my personal opinion is, this has profound implications for how we train our staff. And I can tell you at the Austin, not every doctor gets ALS training. Only doctors in critical care areas, or those who are going to be seconded to the country, or to areas where there's no critical care staff, get ALS training. Everyone gets BLS, but only critical care nurses and doctors get ALS training. And we are trying to focus now on teaching our doctors how to prevent cardiac arrests, because I think you get much more bang for your buck than teaching people how to do what's relatively a simple thing, and for what is going to be responded to very quickly, particularly in our hospitals. Although these events seem quite infrequent, I want to point out that just in ICU-equipped hospitals, we estimated that there's probably about 2,800 in-hospital cardiac arrests a year and an attributable 1,700 deaths. So this is several-fold higher than our annual road toll. And yet we don't have the equivalent of road traffic safety. We don't have the equivalent of, approaches to fixing our roads, etc., etc. Admittedly, these patients are a bit older than those suffering road traffic trauma. However, this is a public health problem. And as Julie's alluded to, until we've done this study, there's relatively poor data, and this was a difficult study to do, surprisingly, just for a simple observational study. We do not have good quality real-time data on cardiac arrests, despite the fact we train every staff member in the hospital to treat them, which I still find a bit silly, but anyway. But the outcomes were better than previously reported. Many of them were witnessed, and many, as I said, too, had a very short duration of CPR. And I don't know, but I suspect it's because we weren't doing pulse checks. So in summary, in-hospital cardiac arrests in this 7-hospital study were relatively uncommon. There are approximately 1 a fortnight per hospital. The vast majority of the patients were from home and independent. So that's reassuring. It suggests, as Julie's alluded to, we are doing some vetting of patients who might not be appropriate for CPR. Although cardiovascular conditions were common chronically, only less than half of patients were actually admitted with a cardiovascular diagnosis as their primary admission diagnosis to hospital. And this is different to out-of-hospital cardiac arrests, where the vast majority of arrests are thought to be due to cardiac problems, either acute coronary syndrome, sudden dysrhythmia, or pulmonary thromboembolism. There's a minority from subarachnoid, etc., etc. And although these aren't completely accurate, I think they're useful fractions. 2/3 were male, 2/3 were under medical admissions, 2/3 were non-shockable, 2/3 got adrenaline, and 2/3 staggeringly got return of spontaneous circulation. A half were in the first 4 days, and a half were in hours, and a half of all of the patients were admitted to intensive care. And this treatment was intensive and often protracted, and 40% have survived, and 2/3 of these survivors actually went home. And that's it. And here's the management committee. Thank you very much. And thank you very much for the data collectors.
Does anyone have a quick question for Daryl, or we can convene discussion at the end? Okay, thanks very much. Thanks, Daryl.